There we go. We're recording. Sorry, Hazel. Take it away.
Thank you very much, Joe. Good morning, everybody. Really good to see you all, and thank you for the opportunity to talk with you this morning. I know you've got a busy agenda. So I'm hoping you can all see my slides okay. As Joe says, my name is Hazel. I'm from the Environment Centre. We're a small independent charity in Southampton. You may well have come across my colleagues Helen and Bea, who presented at this meeting in the past. They'll have been along with our Affordable Warmth project, Southampton Healthy Homes. We do a lot of work around fuel poverty and affordable warmth, but we also deliver air quality projects in Southampton. We're working on a wood burning engagement programme with 4 local authorities to raise awareness of the impacts of the health impacts of wood smoke. And we're also recently been commissioned by Southampton City Council to deliver a Clean Air Champions project alongside Global Action Plan. Global Action Plan, you may have heard of them. They're a national charity. They work on air quality and health inequality programmes. And they've previously delivered this programme in London for London GPs. It was evaluated very successfully. And so Southampton City Council have now commissioned the project for Southampton healthcare professionals. It's funded by DEFRA, and the aim is to improve the health of Southampton patients and residents. So here at TEC, we're the local partners, and we're involved in recruiting and supporting the champions. So I'll just give you a brief outline of the project. So we're recruiting 30 Southampton healthcare professionals to become Clean Air Champions. It's really simple to become a champion. All you need to do is attend a one-off training session, which will last for 2 hours. The dates are there on the screen, so the 19th, 21st and 27th of March. So we're commencing the training next week. And the slot runs over lunchtime, 12 till 2. We've also got some April dates coming up as well. And then once somebody has been along to do their champion training, they'll gain all the knowledge and skills to talk to patients, clients, residents about reducing their exposure to air pollution. And then once the training is completed, they'll come along to a Clean Air Champion network. So this is a group that we're going to create so that champions feel really supported. And they can get personalised advice from us if they like. We'll also be offering webinars every 2 months where we have speakers on specialist topics. So it might be something like gas cooking and asthma in children, indoor air pollution. We'll basically be going into more in-depth knowledge sorry, lost my train of thought there. We'll basically be developing what you've learned in the training and having some in-depth webinars for people to come along to. And then we'll be evaluating the programme to see how it's impacted on both staff and patients. And the project runs until the end of February. So why is this an important project? Why should you get involved? Well, basically, air pollution is called the invisible killer. And until relatively recently, air pollution didn't receive much attention in respect of its impact on health, and yet it is the largest environmental risk to public health. And in the last few years, there's been an explosion in the amount of evidence of the health harms of air pollution. There's hardly an organ in the body that's not affected by air pollution. So it's described by one air quality scientist as a serious systemic insult on the human body, accelerating the impact of non-communicable diseases. So like smoking and lack of exercise, it's a modifiable upstream risk factor. It carries a huge burden of disease and it cuts lives short. And it costs the NHS £20 billion annually. And it's described as an invisible killer because modern day air pollution is really hard to spot. If you look around Southampton, around places like London, on the whole, the air looks clean, and yet it contains a cocktail of chemicals, such as nitrogen dioxide, and tiny particles such as carbon, soot and dust. And they're so small you can't see them. And that's mainly down to modern combustion processes, so modern engines, eco stoves and things like that, where the particles these days are much, much smaller than they used to be. In the old days, we could see black smoke from chimneys and factories. But these days, as I say, it's generally hard to spot. And because the particles are smaller, they are more deadly, because when we inhale them, they pass into our lungs, and then they are so tiny they can move into the bloodstream, and they circulate around the body, causing damage and inflammation as they go. And hence it's described now as the invisible killer. So some headline figures on the impacts of air pollution on health. The most recent research estimates that 48,500 adults die prematurely each year in the UK due to outdoor particulate matter, that the tiny bits of carbon and soot that I mentioned, but that doesn't account for the gases like nitrogen dioxide that come from vehicle exhaust, nor does it account for the indoor air pollution that we all breathe at home and in our workspaces. So we don't have a figure for the total amount of disease, premature death that's caused by both indoor and outdoor air pollution. So it's likely to be much, much higher than that figure of 48,500. Just another headline figure there, air pollution causes over 20,000 respiratory and cardiovascular hospital admissions a year in the UK. So it carries a huge health burden, both to the individual and to society. And air pollution affects us throughout our lifetime. So in terms of pregnancy, it can cause or contribute to low birth weight in babies. And then in children, it can exacerbate or cause asthma, more wheezing and cough, slower development of lung function. And then in adults, it can cause asthma, lung cancer and other cancers, coronary heart disease, stroke, COPD and diabetes. And then in older people, it can increase your risk of dementia, diabetes, lung cancer, heart attack, accelerated decline in lung function and asthma, and a range of other diseases as well. And there's recent reports to show that it impacts on people's mental health as well. So in areas of high pollution, we get a higher rate of depression and anxiety. So it affects our health, both physically and mental well-being as well. So like all major cities, Southampton has high areas of has hotspots of pollution, which means that some Southampton patients will be particularly vulnerable to poor air quality. And these are the 10 air quality management areas in Southampton. That simply means it's an area that has exceeded the nitrogen dioxide annual mean air quality standard, which is 40 micrograms per cubic metre of air. And nitrogen dioxide is one of the most harmful air pollution gases. And the air quality monitors are all roadside, and so the main source of pollution in these areas that is being recorded is, of course, from vehicle emissions. And areas of deprivation are more likely to be close to busy roads, so residents are more vulnerable to poor air quality in these particular parts of the city. We don't currently have data on air quality in Southampton neighbourhoods, where obviously we spend a lot of time at home or at school. But in some areas of the city, we know there are very high levels of air pollution from wood smoke due to the rise in the number of log burners. So what can we do about it? Well, you can become a clean air champion. So a clean air champion is a healthcare professional who acquires the knowledge and skills to offer actionable exposure reduction advice to vulnerable patients in their communities. So you don't need to be an expert, and nor are you expected to be, in order to give some really useful advice to your patients about how they can reduce their exposure to particular sources of air pollution. And a clean air champion learns the skills that allows them to incorporate this advice into their daily consultations. And we also hope that champions will feel enabled to share this information with colleagues throughout their organisations, so that we gradually raise awareness across the city. So by attending a 2-hour training session, either online or in person, it will give you everything you need to advise patients on potential behaviour changes. So some top line messages for patients would include, quite simply, air pollution seriously impacts your health. There are things we can do to reduce that impact, And these are the things that you can incorporate into your daily routine to help you to reduce your exposure. And every time we reduce our exposure to air pollution, there is health benefit. So it's really simple things like walking away from a busy road. If you walk 1 block away from a main road, you're likely to be reducing your inhalation of nitrogen dioxide by 30%, for example. It's thinking about how we cook at home, how we ventilate our homes as well. So the training will help you to offer advice such as that. I won't spend too much time on these patient groups, but basically everybody who sees anybody who's not well will be benefiting from this training. And we're going to be offering some resources for you to share with your patients and clients. So some flyers and posters that can go up in your clinics, or if you're visiting people at home, you can take out some flyers or give them a flyer to take home in a consultation. We're developing these resources in consultation with some local healthcare professionals. These are the resources that were developed for the London project, but we're making sure that they're now redesigned to make sure they're Southampton friendly. And we're making them a little bit more infographic heavy rather than too much text. And we're also looking into whether we can get them translated as well. So if you become a Clean Air Champion, as I mentioned, you'll be invited to attend the Clean Air Champion Network. We'll meet every other month from May until February next year. And we've got some high quality speakers lined up, including Professor Stephen Holgate, who is a UK air quality champion and I'm a brilliant professor of air pollution, air quality work. So we'll also be undertaking evaluation of the project, of course, to see how healthcare professionals' confidence has increased having been part of the training. And we'll also be evaluating patients' knowledge of air pollution, both before and after they have a consultation. And we'll also be looking at how that knowledge translates into behaviour change. So I see that my 10 minutes is up. Thank you very much for listening. If you would like to sign up to become a Clean Air Champion, and we would love to have you on board, then it's a really simple form. It's on our website. I'll put the link into the chat. It takes 2 minutes to fill it out. You can select from one of the training dates that we're offering. If you can't make any of the training dates, please don't worry. Please just tick the box that tells us you can't make the training dates, and then we'll forward you some April dates, and hopefully you'll be able to make one of those. Please do have a look at our website. We've got lots of information on breathing cleaner air, the importance of breathing cleaner air. Please follow us on Twitter, or X as I should call it. And if you've got any questions, you can always email me, or we might have a chance to have a quick chat now. So thank you very much for your time this morning.
Hang on, Phil. Brilliant. Absolutely wonderful. Thank you, Hazel. Absolutely fascinating presentation. I was quite shocked there when you showed the most polluted streets in the city, Victoria Road in Alston, which is a really densely populated area. As you go all the way around, there's a lot of people living around there, yeah, to kind of see the impact that would have on the local population is pretty scary. Does anyone have any questions they would like to ask? Hazel, if you just want to pop your hand up and you can ask. Oh, is there a question? Oh, Elizabeth.
Recently, well, yesterday, I had a patient saying that she suffered with asthma and Calagas was having an impact on her. Has there been any sort of resource research done on Calagas and lung and asthma issues?
That's a really great question. I haven't actually heard of any, but I'm sure there has been. Just because I haven't heard of it doesn't mean to say it doesn't exist, and I could find out for you. If you want to pop your email address in the chat or send me an email, then I'll do some research and let you know.
Brilliant.
But anytime there's combustion, it would make sense that it would affect somebody's asthma, yes.
Okay,
and it may be a case of ventilating the kitchen when your client or patient is cooking, that might help to reduce her exposure. So yeah, I'll follow up and find out for you.
Okay, I'll pop my email in for you. Thank you.
Lovely. Thank you.
Fantastic. Thank you, Elizabeth. Does anyone else have any other questions? No, cool. Hazel, thank you so much. That was an absolutely brilliant presentation, really informative. Will you send me the slides and I can forward round the network? It'll go to a wider group than this, because there's we've got about sort of 20 people here today.
Brilliant.
But it will
Thanks,
go out
Joe.
to
That would be amazing. So far we've signed up 16 champions,
Oh,
so
cool.
we've got 14 places left. So I'd really appreciate if anybody would share it with colleagues they think might be interested. That would be amazing. And I'll put the little form in the chat now so people can sign up if they wish to. So thank you very much for the opportunity to speak with you this morning.
You're a
Thanks.
dream. Thank you, Hazel. Brilliant. Thank you very much. And if you think of any questions for Hazel afterwards, then yeah, please just let either myself or Hazel know. Fantastic. We'll move on to the next speaker, who I think is Joe Payne from Healthwatch.
Hello.
Hello, how are you?
I'm all right. I'm all right. I
I'll
don't
be
have a fancy presentation, Joe.
That's okay. Just
Okay.
just you is fine. Just you is fine.
Okay, cool. Okay, so yeah, Joe's asked me just to come along and give you a bit of an overview of who we are really and what we do. Okay. So I'll try and squeeze that into 10 minutes. So Healthwatch was established 2013, and I think there's about like 150 across England. So whatever your postcode is, you kind of tap it in, and you're directed to your local Healthwatch. So Southampton support residents and listen to residents from SO14 to SO19. And the idea was it was set up to be the health and social care champion. That's the strap line anyway. And it's all about, increasing the power of the public's voice to make those changes in health and social care services. So we do a lot of outreach. So anybody who wants me to come along to a group in a community, I'm happy to do that. To kind of hear what people have to say. We have online, we have like a feedback centre, so anybody can say what they feel anonymously about services they're involved with, good, bad, indifferent. It's really good to hear about good stuff, but as you can imagine, it's not a lot. Not a lot at the moment. I think people forget to kind of share anything that's going well. People can contact us on phone, or you can just send us just an email. But like I said, it's much more powerful for us to go out and hear what people have to say. And then, we kind of keep a track of what people are saying. And if there's any themes, we might kind of investigate a little bit more and do reports out of that to find out what is actually going on. Is there a trend? And then with this feedback, we will share that with lead decision makers and commissioners within the city council or the NHS to say, look, this is what people are saying, what you're going to do about it, and kind of hold them accountable. So that's it in a nutshell, what we do. We also support people, signposting them to other services, but also if they want to make official complaints about their treatment, so we can support them and get them in touch with the advocacy people to do that. Currently, we are running our annual priority survey, so we're trying to get as many residents of Southampton to complete that, asking people, what are their top 3 priorities that matters to them, and then that will kind of shape what work we do the following year. What do we need to investigate? So please, if you're a resident of Southampton, fill it in, share it. So that's it. I know it's very brief, but that's Healthwatch. Does anybody have any questions?
Yasmin has a question.
Hi, Joe. Thanks for that overview. I'm just curious to know what kind of positive follow-up you've had from council, for example? Have you got any examples of where they did follow up on something you put to them?
I can't think off the top of my head. I mean, there's stuff going on at the moment regarding dentistry, and in particular the dentistry strategy. And we asked, what is your take on that? We asked, we put that to the council, and they didn't have one. So we kind of like, well, you need to have an input into that. So that's ongoing. Yeah, but nothing in particular.
Okay,
I can
thanks.
find out for you.
Yeah, it would be really interesting to know. Thank you.
So in particular, the city council, yeah?
Oh, anybody, any sort of organisation that's taken on board something and tried to follow up.
I will say any work that we kind of do with, in particular, the big hospitals, it takes a long time to then get any reports finalised. It goes backwards and forwards, and they do kind of scrutinise what we're saying. They don't like to be challenged.
Thanks, Joe. Thank you.
All right.
Thank you. There was a good bit of work that you did with Alzheimer's Society last year as well. We talked a little bit about that.
And that is ongoing. That is like so this is a piece of work that started in 2022 actually. So the Alzheimer's navigators approached us and said, look, we're hearing loads of stories from patients and carers in particular about their treatment of patients with dementia in the general hospital, and like reading it, some of it was horrific. You're like, no, that can't be true. But there was too many stories for it to be just a one-off. So we decided to kind of explore that a little bit more, and take it on as a project. And we collated those case studies that Dawnie and Chris had, and we interviewed carers. We then kind of did a workshop with the dementia navigators and NHS staff to say, what is actually going well now, what can be improved, and what's our recommendations for the future. So that is currently in draft report format, and we are liaising with the general hospital to kind of finalize that. But yeah, it can take quite a while to finalize pieces of work.
It was a really good piece of
It is, and some really good things have been born out of that, because now they have like a drop-in hub for carers, patients within the hospital. If you have any issues about your loved one who's got dementia, that wasn't happening before.
No.
And even though the navigators have gone, that is still happening. So there's some really good stuff happening.
Gary, who's one of the team from Alzheimer's who took over, is in the chat, and he said fab work, Joe Payne, and he's come on screen.
You.
Face to face. Fab work. Thanks, Joe.
Thank you very much.
I look forward to seeing the final report. We know these things take a lot of effort and a lot of time to bring it out and get it openly discussed.
Yeah.
So yeah, we look forward to that. Thanks very much.
Thanks,
and Healthwatch isn't about bashing services and saying you should be doing this. Everybody is under immense pressure. But yeah, it's still important that we're hearing from people when things aren't going right.
Absolutely.
Yeah.
Absolutely. Thank you. Ali has very patiently had her hand up. I think she might have frozen actually. Ali, are you there? I think she may have frozen. Just while I wait for her to reappear. Joe, are you there? Oh, I think she's gone. Just a quick question from me, Joe, and then we'll see if Ali comes back. What's the referral process? How can someone be referred in, and what can they expect when they're referred in?
I would say it's referral, just get in touch with us. So you can phone us, like I said, you can email us directly, you can contact our feedback centre online. Shall I put all my details in the chat, Joe?
You can do, or just send it to me, because I'll send out
Okay.
the link to this. Sorry, I forgot to mention at the start of this meeting, it's recorded, it gets put on YouTube, but in a sort of I'll send the link out so any kind of people with the link can view it for the first couple of weeks. Ali, you're back.
Yes, sorry, a bit
That's
of unstable Wi-Fi at this end. Joe, I just wanted to ask you, I'm from Read Easy, and we support people who struggle to read, and we provide coaching for adults who have poor reading skills. I have one anecdotal story from one of our current readers who had quite a surprising experience at the General Hospital, where it was quite clear that the clinician that was dealing with her really didn't understand the concept of somebody not being able to read, and was quite sort of abrupt and didn't really have an understanding of the situation and how to perhaps suggest alternatives for somebody who can't read, a takeaway set of instructions and messages and so on. So I'm just wondering if this is the kind of thing that perhaps we could get some help from you to make some inroads with the hospital, because I've tried to approach their access officer and the head of this particular service where this was concerned. Haven't had any response, not surprisingly. But I'm just thinking it's probably a wider question about clinicians understanding differing needs. Whereas, for example, they might have a good understanding about how to approach somebody who's visually impaired, but if somebody can't read because they cannot read, they don't have reading skills, it's a different take on the situation. So I'm just wondering what you'd sort of suggest as a way to try and make some contact and get some dialogue going with the organisation, because it is about accessibility, really.
Interestingly, the project that I'm deeply involved in now is all about accessible information standard.
Right.
So no thank you, Sam, sorry, I'm asking if I want a cup of tea. So we've been working with the other 3 local Healthwatches, so Portsmouth, Hampshire and the Isle of Wight, about the accessible information standard. And I've been in particular working with Southampton site. So we've been working with lots of different groups, people with, learning disabilities, sight, hearing impairment, people who, like you said, just, their reading levels are quite low.
Yeah.
And, that again is in draft report at the moment. And we're looking at what next steps we need to take in terms of to make a really big impact. We don't want it to say, oh look, we've spoken to these people, we've produced a lovely report, off you go. We think this is going to be a bigger piece of work. So yeah, contact me after this. It'd be really interesting.
Yeah.
Yeah.
It would be good to develop it as a stream where we could say we'd done something to support those particular needs. And I was also thinking particularly about professional training, in the kind of understanding of accessibility.
Yeah.
Yeah. Okay. I'll email you.
Yeah, do. That'd be really good.
Thank you.
Smashing. Brilliant. Thank you. Thank you, Ali. Any other questions? Well, I'm going to take this opportunity right now that we're actually running completely to time for a change, so I'm very pleased with myself. Well done, everyone so far. Brilliant. Without further ado, I'm going to pass over to Angie Whitmarsh, who's here to talk to us about Diabetes UK. Good morning, Angie.
Hi. So
Hi,
hopefully I won't ruin that for you, hopefully.
It's okay. Thank you.
Right, so good morning, everyone. So first of all, a bit about me. I was diagnosed with type 2 diabetes back in 2005. It was my second encounter, if you like, or third encounter with diabetes, as I had it with both my pregnancies. I had gestational diabetes. After the second pregnancy, it was worse in the second pregnancy. I said to the health professionals at the time, so what does this mean now that I've kind of had this twice? Because it's really weird, because it's almost like a light switch. The baby is born and everything goes back to normal. And I was told, well, just tell your family and friends, and if you collapse later in life, get them to check you for diabetes. And that was all I was told. So in all fairness, that was 30 years ago, but the message that gave me was, we're not that worried about it. So I took away from that, if you're not that worried, then I'm not that worried. And in hindsight, who's to say that I perhaps wouldn't have taken better care of myself with my diet and my exercise and what have you. So fast forward to 2005, and I was diagnosed with full-blown type 2. I retired in April 2010, and I then went to a meeting to set up a diabetes support group with Diabetes UK. Since then, I have been the secretary and chair of the group. So we began meeting in halls, having face-to-face presentations. COVID, we went on to Zoom, and COVID really changed the whole structure of our meetings. We went from being very focused and this is the information about diabetes, this is the stuff you need to know, to literally being chatty about absolutely anything. And it really kind of changed the dynamic of the group. And a lot of people said that, you know, they kind of had to remind themselves that they were coming to the group to find out and support themselves with their diabetes, because they felt like they were just coming along and chatting and having a laugh with a group of friends. And we've not lost that since then. We still haven't gone back to meeting face to face in a hall, because we lost our hall, and where we were kind of doing the hokey cokey coming out of COVID, you can meet up, you can't meet up, you can meet with a few, now you can't meet at all. People were quite reluctant to actually get together face to face, and because we had to pay for the hall, I was reluctant to lay out and not know how many people would come. So we've continued with our Zooms. We still do Zoom coffee mornings, we do Zoom education, but we do now go for walks as well. We're called the Southampton and District Group, and I put the district in there because groups like ours are very few and far between, because they are run completely by volunteers and there are a lack of volunteers to actually take on these roles. So we don't turn anyone away. If somebody wishes to come to a face-to-face meetup, if they're prepared to travel to where we are, they are very welcome. Obviously with Zoom, it's much easier, and we still have people logging in from Thames Valley, from out of county, and from all over Hampshire. So that works absolutely fine. In all the years I've been doing this, I've kind of become a bit of an expert patient. I sit on various medical groups, research groups. I've been involved with CCG meetings with diabetes network services, now integrated care boards. I'm on the district prescribing committee. I regularly interact with the inpatient team in UHS. So being part of the group, which basically just involves sending an email, I will basically send out the information of what's coming up, what sort of research people are wanting people to join in with, and people are interested, they can do that. I go to every type 2 newly diagnosed and refresher education course at the Royal Southampton, and I do a kind of a 10 minutes on my diabetes journey and what the group can offer. We have, in the last 6 months, been very kindly given a room at a care home in Hedge End. Very nice lounge. They let us have the room for free, and they give us free teas and coffees, and we can literally just go there, sit and chat. They put it on their timetable for the residents, which also goes to the families. So if anybody wants to sort of pop by and chat, because I did stress we don't just talk about diabetes. The home were quite enthusiastic about this, because I'm sure you all appreciate a lot of the residents don't get many, if any, visitors. So just to go and chat with a different group of people, and it works really well. And we're very grateful to have that facility. We've also got a WhatsApp chat, which from my point of view is absolutely brilliant, because at the moment, emails, updating the Facebook page, responding to things like that, all has to come from me. There's nobody else that kind of shares that with me. But with the WhatsApp chat, they basically just sort of jump on, ask their questions, and they're all interacting and answering each other. For example, Abbott updated their Libre a few months ago, and as with all these technical updates, it didn't go smoothly. So people who are using the Libre were literally jumping on the WhatsApp chat. Well, I've tried this, and this is the reply I've got from Abbott. And when you download this, or you go to this website, and basically all just supporting themselves. We very recently had a lady, a very mature lady, shall I say, who was quite out of the blue, diagnosed with type 1, released from hospital with very little information. And luckily she found our group. She was very, very much out of her depth, didn't have a clue what was going on, and very frightened. And we were able to, because we have a huge number, we're very unusual in the fact we've got a huge number of people living with type 1 within our group, and they were able to directly offer her support and advice along the way with that. So we have 95 people that we regularly email, but of course with emails, you never know these days if the email address is still active or if it's just buzzing off into the ether. I'm more than happy to add anyone to that email, because as I say to all the newly diagnosed that I talk to, like any social media, if you're not interested, or it doesn't affect you, or you don't want to know about it, just scroll past it or delete it. But it will tell you when we're going for our walks, whereabouts we're going, when we're meeting for coffee, and what our next Zoom presentation will be. Earlier this week, we had a presentation from the retinal eye screening people. A lot of the group have asked for that, because the retinal eye screening people have told us that, as with all services, they are now going to be cutting back with the retinal screening. So whereas before a person living with diabetes will be screened every year, if they find everything looks fine, they will make it every 2 years. And as you can imagine, that has caused quite a bit of panic and quite a bit of angst among people, especially as we've got one lady in particular who developed some very serious eye problems within a few months of actually having her retinal screening exam done. And so her argument then was, if I then had to wait 2 years, what then would have happened? Because obviously with diabetes, your eyes, your kidneys, your feet in particular are all very much at risk. And anyone living with diabetes, once you start to get an issue, it accelerates. The higher sugars in your blood make everything so much worse. So, as I say, quite happy to add whoever. We have a Facebook page. Please do stress with the people that you are seeing. There is absolutely no obligation to get involved in any way other than that what they are comfortable with. They can join a Zoom meeting and sit there with their camera off, with their microphone off. They do not have to engage, just as long as I know who they are, because obviously I need to protect the rest of the group. Then there is no badgering, there's no onus, you have to do this, you have to do that. But people with diabetes can very easily feel very overwhelmed, very much on their own, and it's really just to impress upon them that they are not alone, and there are people who feel exactly the same as they do. Friends and family are also very welcome, because quite often I know the patient themselves aren't ready or don't want to hear this advice, but the family members panic and worry and think, well, we need to be understanding it more. We need to know what we can do to help and support them. Okay, I think I'm 4 minutes under time, so woohoo me.
Angie, that was brilliant. Thank you. That was incredibly informative. Just a couple of questions for you. So you mentioned that, you know, you sort of do groups. What sort of places do you go for kind of walks and things? Whereabouts? All over the city? Or?
We try to vary it because we are aware that not everyone has access to vehicles. I say a care home is wonderful, but unfortunately being in Hedge End, it restricts quite a lot of people. One of the most frequent places is the Common, because we will have people turn up on sticks, in mobility scooters, things like that. We will have people that can't walk very far. So we need to make sure we've got sort of tarmacked even paths, benches where people can stop. And it really is a stroll. I mean, one of us turns up dressed like Indiana Jones, and it terrifies the life out of people because they're like, oh my God, are we going up a mountain? And it's just like, no, he walks everywhere. You know, he's walked here from Chandler's Ford. He's happy to walk. And people walk at their own pace, and they have all kinds of little conversations. And in fact, the care home was very special because it was the first time in a long time we were all together in one room, and there was one conversation that everyone took part of, instead of having all these little sort of groups. I will put the email address into the chat. It's a stupidly long email address. It's ridiculous, but so if you just send me an email, say who you are and ask to be added, and I will put you into our group distribution list.
Brilliant. Thank you, Angie. And just as well, just one last comment from me, you know, really wonderful to see a kind of grassroots organisation really supporting a community of people who go into a very scary time in their life. A condition that's, well, given the given how much sugar is in food, for example, you know, a lot of people as we go forward are likely to be at risk of diabetes and conditions, and it can be a very lonely place when you are diagnosed with something like this, and you know, not always able to freely access support, more often than not peer support. As I've said in this group many times, we used to work for the carer service, and when we used to do our peer support sessions at carers, you know, the carers just like to talk to other carers because they understood what they were going through. It wasn't, they didn't kind of feel preached at by a professional. It was just talking to someone who understood the challenges of being an unpaid carer, or in this instance, you know, what it's like to live with diabetes. So brilliant.
And I'm also more than happy for any of you to join in your professional capacity. You don't have to identify yourself as a health professional. We won't point you out so that you get bombarded with questions or anything, but it's a very good experience, so I've been told, to just sit there and listen to patients talking to other patients, because you perhaps hear things that they might not say when they're sat in front of you. And I mean, like any doctor's appointment, you know, you've only got your specified 10 minutes. You go in there thinking, right, I've got to say this and I've got to say that, and you come away and you think, I didn't ask that and I didn't ask that. Somebody else will bring it up in a conversation, and then it will be, oh yes, I wanted to find out about that because that affects me too. So we're more than happy for you to sort of sit and listen and just kind of get that feedback.
Brilliant. Getting people to share their stories is always such a brilliant way to find out what's going on and also find out ways to help people. Fantastic. Does anyone have, excuse me, any questions for Angie? Cool. Fantastic. Thank you so much for coming and keeping to time as well. Gold star for you. And if anyone thinks of anything, we'll send it on afterwards. But yeah, if you pop your details in the chat and people can get in touch. We're brilliant. Thank you so much for coming. Let's keep on a roll. Daniel, hello. Here to talk about target lung checks. Good morning.
Morning. Hello, everyone. My name's Danny. I work for the Targeted Lung Health Check Service. I've got a presentation and I will share it. How do I make it bigger? Is that working?
Yeah, looks good. Yeah, so it's a bit small.
Yeah, I'll try and make it bigger.
Cool. Yeah, perfect.
Lovely. So as I said, I work for TLHC, which is Targeted Lung Health Check Service. We have actually been running in Southampton for 4 years, and we do work with primary care. I'll go over that in a minute. I'll try and be as brief as possible because you've had a lot of services. So I'll just let you know what we do and how you can help. So the aim of the programme is to identify lung cancer stage 1 or stage 2, where treatment options are much better and patients could potentially be cured or into remission. And we're very successful in that. We, as a pathway, we invite patients via the GP surgeries. So we will send letters on their behalf. They'll contact our admin team. We will then check their eligibility for the programme. And this is probably the most contentious part of the programme. So we are able to screen. It's a directive from NHS England. We're able to screen patients between the ages of 55 and 74. They have to have smoked more than 100 cigarettes in their lifetime, which seems like a bit of an arbitrary figure, but that's the figure that we go with. And we screen patients from Southampton City, and we have done for 4 years. We've recently expanded to Totton and Hedge End in June last year, and we'll also be in Romsey, North Bannisley, and the New Forest at the end of this month. Fingers crossed, as long as everything goes well. So we invite patients, and they call up. We just double check their eligibility. If they're eligible, we will invite them for a lung health check, which is a phone call with one of our nurses. They'll go through a questionnaire of past medical history, smoking history, risk factors such as exposure to asbestos, and high risk professions such as dock workers or miners. And those questions will then generate a risk score. If a patient is high risk, they'll be invited for a CT scan. And that is done on our mobile trailer, which is just outside the Royal Southampton Hospital. So really nice and central. And then we will screen patients every 2 years until they reach the age of 75. So why is the programme here, and why do I have a job? Previously, the UK had one of the worst lung cancer survival rates in Europe. TLHC started as a pilot 4 years ago to combat lung cancer, and it was a directive to be placed in the most deprived areas. So it was in Manchester, it was in Liverpool, it was in London, and Southampton was also one of the sites chosen. Before Target Lung, it was lung cancer was most prevalent and identified latest in the most deprived areas in Southampton and across the country. Because of Target Lung, and because we've contacted them, contacted most deprived areas first, we've now flipped that on its head. So the least deprived areas have the best outcomes from lung cancer, and the most deprived, the least deprived areas now have the worst outcomes, which is because of the efforts of screening. This is just some general data into the programme. So we've invited 46,000 patients here or there. We've completed around 12,000 scans, 6,400 initial scans, and 5,400. So that's 11,000. 5,400 follow-up scans. We sent 407 referrals for lung cancer, and we've identified 213 lung cancers. 82% of those in stage 1 or stage 2, which is fantastic. Which generally they have metastasized, and treatment options are so much better. So what can you do? The best thing that you can do is to signpost patients. You'll get a lot of patients who are worried well, or they are concerned about things like having smoked previously in the past, not even being a current smoker, or currently smoking, looking to quit, and worried about their health. If you have patients who fit that eligibility criteria, which I know is quite stringent, we would be very happy to see them, and we would screen them, and we accept self-referrals. We set up a self-referral pathway, I think, about a year ago, and we've had 150 self-referrals since, which is a huge number, and we're really happy with it. We would really encourage patients to call in, contact the service, and we will see them as long as they fit that criteria, as I said. I will share some comms materials, so some leaflets, some posters, and I've just realised I've missed an 8 on our number. It's supposed to be 0238 120 8883. And this is actually very good timing because I see you're all from Southampton City. We are just about to start re-inviting patients who have previously not engaged with the service, patients who've moved into the area from another area, people who've aged into the programme as well. And we're going to do that next month for about a period of a year. So you will probably get some queries from patients. They might question if you've heard of it. So if they do have any queries, or you have any queries, please don't hesitate to contact me. And we also have a Facebook page that patients can contact us on too. That is it from me. Does anybody have any questions?
Brilliant. Thank you, Danny. Absolutely fascinating presentation. Does anyone, I think there's a hand up. Hazel. Excuse me.
Hi, thanks, Joe. Hi, Danny. That sounds like an absolutely amazing initiative. Congratulations to you and the team. It's fantastic. Just a quick question. In your screening calls to patients, do you ask about solid fuel burning at home? Whether people are using, log burners to heat their homes at all? I'm just interested because I've noticed in research that there's a rise in the number of lung cancer cases in non-smokers, particularly amongst affluent women. And I've heard that that's possibly down to the rise in log burner usage across the country. So just wonder whether it's something that you talk to patients about.
Because this is a pilot programme and a directive from NHS England, there are so many things that we want included and that we're lobbying to be included that currently aren't. So we currently don't include patients who are passive smokers. We don't take into account patients whose parents have died of lung cancer and the genetic element. And that's another thing that isn't included in our programme that we would like to include and add as a risk factor and a factor that can generate a risk score as a high risk. So unfortunately, no, we don't. But in the next couple of years, we expect our programme to transition to Public Health England, where they will start taking into account other risk factors of cancer, lung cancer, and bringing them in.
Brilliant. Thanks, Fanny. It's really interesting. Thank you.
Brilliant. Thank you both. Any other questions for Danny? Brilliant. I think we're good. Daniel, thank you so much for coming, for presenting today. If you just want to send me the details over, I will get those distributed out with the recording of this presentation. Really interesting to hear about the work that you're doing. And when you said that you really managed to flip the deprived areas to being really well supported, that was absolutely wonderful to hear. To really yeah, fantastic work. Thank you so much for coming. It's been really brilliant to hear from everyone today. And thank you to all of our presenters for a really interesting and rich and varied conversation that we've had this morning. Thank you so much all. I'm going to stop recording there and we can take a sort of 5-minute break if you want to go and grab a cup of tea or go to the toilet or whatever. We'll reconvene at sort of 11:05 and do some catch-ups and sort of a bit of networking and sort of find out what's going on. Our speakers, you are welcome to stay and sort of join in as well, or if you have to head on, I know how busy we all have other meetings and things, and again, to anyone else in the room, if you need to head on, that's absolutely fine. Thank you for coming, and we'll catch up 5 past.
Thank you very much, everyone. Bye-bye.